Alright, this class is the cue-based feeding initiative. So what we're going to talk about today is what is cue-based feeding and how is it going to change our current practice. So it's a method to transition infants from gavage feeds to complete total oral feeds. The infant is in the driver's seat and they will help us decide when they are ready to feed. It's up to you as the nurse that's caring for the baby to recognize and interpret their cues and know when it's appropriate to feed or not to feed that baby. It's a systematic method which will guide the nurse through that transitional process of gavage feeding to oral feeding. You as the nurse will fairly independently move the baby through the progression of feeds. There will no longer be those daily orders to PO feeds or advances tolerated. Many of you may have seen feed every other feed or 4 times a day. We will be using some algorithms and some readiness and quality scoring tools to help us advance those feeds. You also, as the nurse, will be responsible for updating the medical team during daily rounds and let them know how the baby's oral feeds are progressing. There is going to be documentation in EPIC to help you back up your decisions. So the objectives are preparing the very low birth weight infant for PO feeds here in the NICU. We'll define feeding, volume-driven feeding versus cue-based feeding. Volume-driven feeding is what we have done here in the unit for a very long time, and we are moving to a cue-based feeding program. We'll discuss cues of readiness and the signs of stress. We're going to discuss the readiness scoring tool as well as the quality scoring tool. Cue-based and breastfeeding algorithms, those are those colored sheets. Compensatory techniques that you use, and the EPIC charting. So, to prepare the very low birth weight infant for PO feeds in the NICU, our goal is to decrease the time to make it to full feeds and decrease the length of stay for each child. We use oral colostrum along with oral care, skin to skin, and oral feeding to meet that goal. Our present practice is oral care with colostrum. We use that within the first 5 days. This practice began back in June when we went live with our new feeding guidelines. We should be doing this every 3 hours when we gavage feed as long as there's colostrum available. The rationale for this is it provides oral immune therapy, it aids in gut maturation, and decreases our risk of BPD, neck, VAC, and sepsis. We're going to begin taking it a step farther from just colostrum to milk drops. Once colostrum is no longer available, oral care should be continued with breast milk, donor milk, or formula. That is a bit of a change. Currently we are only using mother's milk, but we are going to start using whatever form of milk the baby is taking. 40% of all preterm children are treated for some type of feeding disorder, whether that's in the NICU or later on as an outpatient. The major reason for the increased risk is the structural differentiation in the brain. It changes rapidly between 23 weeks and 32 weeks. And we have a diagram here. You can see a 25-week, 30-week, 33-week, a term infant, and an adult. And you can see the structural areas of their brain are very different as they move through. Babies born at 23 weeks mean that they have about 9 to 11 weeks of negative stimulus during that time of structural differentiation. So it's important that we're giving them positive feedback while their brain structure is occurring. Tube-fed infants increase their non-nutritive sucking when they're exposed to the smell and taste of their mother's milk. This will also assist in our transition to oral feeds. Implications for the practice. It allows for enjoyable oral experiences and also allows for the parents to be more involved. So how are we going to do this milk drops? Mouth care should take place at the end of a baby's hands-on time. I know many of us do it at the beginning right now because it's clean and we want to do all the clean steps first. But really developmentally, it kind of gives them some pleasure at the end. So we'll try to do that at the end of each hands-on. The baby should be in side lying and midline, and that will help preserve their energy and make them feel safe and secure. Boundaries should be provided to make the baby feel secure. Those are things we do always, so that's not really a change. And the baby should have their hands close to their face, and it helps them organize and comfort themselves. So milk drops given with cares and cavage feeding, that consistency helps that synaptic process to develop. So feeding, I love this one, right or left, where are we going to feed today? Because our baby should be inside lying, whether we're doing the milk drops or feeds. A quote here is, nipple feeding is a complex, highly coordinated sensory motor task, and the preterm infant has to reach a certain level of developmental maturity to be successful in the oral feeding process. It also requires a skilled, observant caregiver to assist the infant in achieving a pleasurable experience, as well as maximizing the intake and minimizing the stress. And minimizing the stress is a very important key to that. Feeding is a relationship-based experience through which communication interactions build trust. So we want our babies to know that they can trust us. Volume-driven feeding is where Mary Jane's going to take over.
So I'm going to talk a little bit about the difference between volume-driven feeding and cue-based feeding. Volume-driven feeding historically is where NICUs have practiced feeding and how we've practiced feeding our infants. And this is the practice we're moving away from and transitioning to a more cue-based feeding approach. So with volume-driven, the goal is quantity. Baby needs to eat a certain amount every 3 hours to be successful with feeding. The culture is we have to get these infants to eat. And it kind of breeds a competitive nature because oftentimes I'll hear somebody say, well, the nurse last night got the baby to take the whole thing and he wouldn't take but 5 mLs from me. As we're moving away from that volume-driven to a cue-based, that kind of everyone's on the even playing field and there's not this competition going on of who can get the baby to eat. With volume-driven, we oftentimes feed past the baby's stop signs or what their stress behaviors are. We provide caregiver modifications to keep the baby eating, and those might include increasing the nipple flow rate. Oh, that baby's getting tired, they need a faster flow. Or twisting or shaking the nipple, unswaddling to get him awake, rubbing his face, neck, or head, squeezing those cheeks, anything we can do to stimulate that baby to keep eating. And not recognizing the stress, that those could be stress cues of why he's not eating and why he stopped. Infant behaviors like falling asleep, turning away, pushing the nipple out, some gaze aversion, physiologic stability, those are oftentimes ignored in a volume-driven approach. Shaker in 2013 said, a focus on emptying the bottle or defining an empty bottle as success may negatively affect the preterm feeding experience and have adverse effects on the neuromaturation and on feeding outcomes. So going back to Ashley's slide where she showed the brain of a 23-weeker up through an adult, the developmental care approach looks at one brain for life, and we have the ability to impact this brain neurodevelopment for a lifetime. So what we're doing, even in a feeding practice, is going to impact the baby's feeding through a lifetime. So we want to keep that as positive as we can. So this just little slide picture here is to illustrate that one size doesn't fit all. We're going to move towards cue-based and it's a little bit more individualized. So what is cue-based feeding? With cue-based feeding, success is measured by quality, not quantity, positive experiences, and safety. We want to teach a baby to feed with positive feedback and safety as our primary focus. So we are going to be learning those babies' cues, reading those babies' cues, and responding appropriately. Intake should increase as feeding skills develop. So as we see feeding skills develop, quality is going to follow that, and then volume follows that. It's a normal, natural progression. Volume completion is not the goal. Cue-based feeding supports physiologic stability and the developmental feeding progression. It requires a skilled and observant caregiver, which is you all. You're going to be feeding these babies. And parental involvement is crucial. The parent needs to be able to recognize the cues and stress signs, and they need to be able to feed their baby as early as they can in the process. This is also an important part for you all as bedside nurses to recognize, because you're with these babies every day, and the parents are going to come in, and not only are you going to be feeding these babies and learning their cues, you're going to be teaching the parents what those cues are and how to appropriately respond. Another part of that is when the parent calls in the morning, they may say, hey, I'm going to be there at 11 and I want to feed my baby. Well, moving towards a cue-based, we're going to have to start educating our parents and talking to them in a little bit different language to say, okay, we're going to score the baby's readiness when you come in, and if he's showing scores that he might be ready to eat, then we can attempt at that time. But if he's sleepy and not wanting to eat, you're welcome to hold him and offer his pacifier. So our goals of cue-based feeding is that it will be safe, it will be functional, nurturing, individually and developmentally appropriate, a pleasurable experience that maximizes intake and minimizes stress. So what are the cues that babies show us that they are ready to feed? They're drowsy, alert, or fussy before care, so they may be waking up feeling that they're hungry. They're rooting around. You touch their cheek and they're turning, trying to find where that touch came from. They're bringing their hands or fingers to mouth and sucking on those. They may be nuzzling, licking, or lip smacking. There is physiologic stability. They might accept their pacifier with a sustained sucking pattern. And then there's good tone. There's nice flexion that prepares them for feeding readiness. Oftentimes, we see one of these, like the baby may be alert, but say they're not rooting or not bringing hands to mouth. I want to encourage you to look for multiple cues of readiness when we start to feed, because the more cues that we have, the more ready they are, the more it's going to ensure that this could be a successful feeding. So signs of stress. This is a list that I created. It's not exhaustive, but it lists some of the main signs of stress that we sometimes see. Baby may not have good posture, maybe tachypnic, have some nasal flaring, some state changes, color changes, hiccups, finger splaying or stop signs, brady's or apneas, desaturation, yawning. If they're nipple feeding, they may be spilling a lot or losing parts of the bolus, gulping, gurgling, coughing or choking. If these signs of stress are seen during the feeding, the breast and bottle feeding should be stopped, the remainder gavaged instead of force feeding the remainder by twisting, pumping the nipple, which can increase the risk of aspiration. So if you see multiple signs of stress, like the baby's telling you, I'm struggling, don't force or push to keep feeding. Let's just stop and gavage at that point. Let's talk a little bit about twisting or pumping the nipple. Sometimes that's a technique that I see to kind of encourage babies to keep eating. However, when you do that, you're continuing to pump milk or increase the flow of milk into the oral cavity, and then they have to figure out how to swallow it safely. So by doing that, you can increase the risk of aspiration, therefore jeopardizing the safety of the feeding. So please be very careful with any manipulation that you do of the bottle or the nipple. This is how we want our babies to look after a successful feeding. Like that was the best thing they had experienced all day. Ashley's going to talk about the readiness tools. So
the readiness scoring tool. We're just going to go over this line by line. The things that we're scoring are state of consciousness, feeding readiness cues, tone, physiological stability, and stress. Those combined will give us a readiness to feed score. So we'll start with state of consciousness. On each of these scores, you can receive a 0, 1, or 2. So if they are drowsy during or after the care, they get a 0. If they are drowsy but they wake up during their hands-on time or their care time, they would get a 1. If they're awake prior to the care, fussy or eager, looking ready for their bottle, they would get a 2. The next section is feeding readiness cues. No feeding cues present and won't take their pacifier is a 0. Some cues, rooting, or will suck on the pacifier briefly but don't bring their hands to their mouth, that's a 1. And if they're rooting before you start their cares, they're sucking on their hands, or you can put their pacifier in and they're able to maintain that hold, that would be a 2. Tone. Non-flexed body position, so they're just kind of laid out. That would get them a 0. Loss of tone when you handle them, so the more you touch them, the more disorganized they get, would be a 1. And then good tone with appropriate flexion, so they're bringing themselves into midline, would get them a 2. Vitals. If they're apneic, bradycardic, tachypnic, and tachypnea is defined for this purpose as a baseline above 70 breaths per minute. All of those things will get the baby a 0 for readiness. A stable respiratory rate with intermittent tachypnea during cares will get them a 1. And if they have no change in their vital sign and they're above or below their baseline, that gets them a 2. Stress. Hiccups, nasal flaring, increased work of breathing, finger splaying, so there's stop signs, raised eyebrows or frequent eye blinking, or just really big eyes, a grimace present. If you have 2 or more of those stress signs, that gets a 0. If you have those stress signs present, but they're only intermittent, and they're absent when you provide good boundaries or swaddling, a support to that baby, they'll get a 1. And then no signs of stress, they'll get a 2. So once you add all of these up, the total that you can get is a 10. If you have a readiness score of 5 or greater, then you would proceed with feeding that infant PO. If you get less than 5, it would be appropriate to cavage feed that baby during that care time. It's important to know that if you get a 0 in any category, that's an automatic stop. So if you guys will turn this over, it has the quality scoring tool. And for quality scoring, we are scoring suck, coordination, state of consciousness, physiologic stability, and stress. And those categories give us a quality feed score.
Okay, so we'll start with suck. The baby would receive a quality score of 0 if he doesn't actively open his mouth or has an inconsistent, weak suck. A 1 for a consistent suck with compression of the nipple only and moderate loss of milk. A score of 2 with a strong suck, actively opening the mouth and dropping the tongue when the lips are stroked with the nipple. For coordination, the baby would receive a 0 with an uncoordinated suck, swallow, breathe pattern, resulting in a change of their vital signs. Gulping, rattling, or choking sounds are present. A quality score of 1 for strong coordination of suck, swallow, breathe initially, but fatigues with progression of the feed. And a coordination score of 2 with a strong suck, swallow, breathe pattern throughout the entire feed with little loss of milk and no change in the vital signs.
With progression of the feed. The next category is state of consciousness. If they have no change in tone during the care, or they they lose tone early or become tired during the early part of the feed, they get a 0. If they're alert with fair tone initially, but they become drowsy or lose tone late in the feed, they would get a 1. And if they're awake and alert throughout the entire feed with good sustained tone, they receive a 2. Physiologic stability. So, they would receive a 0 if they have greater than or equal to 2 apnea or Brady desat events during the feed that led to a color change or tachypnea. They would receive a 1 if they have less than 2, so 0 or 1, apnea, Brady, or desat spell during the feed with intermittent tachypnea. And if their vital signs remain stable throughout the entire feed and they have no physiologic change, they would get a 2. The last section is stress, and you'll note that it's exactly the same as the stress on this readiness scoring tool. We'll go over it again. Hiccups, nasal flaring, increased work of breathing, finger splays, raised eyebrows, frequent eye blinking or grimacing. 2 or more signs of those stresses is a 0. If they have stress signs present intermittently with their cares, but they improve with swaddling or boundaries or support prior to the feed, they'll get a 1, and no signs of stress, they get a 2. Again, the quality scores were going on 0 or 5, so if they receive a 0, you would stop and gavage the remainder. If they receive greater than 5, you would continue with the current feed. Less than 5, you would stop and again gavage the remainder. So we're going to move on to the cue-based feeding algorithm. That's the sheet. So I want to start out by saying that 2 liters high flow cannula equals a critical status. This is a bit of our change to our current practice. So if the infant is 30 weeks, they're receiving bolus feeds, and they have no signs of respiratory distress, then we can begin non-nutritive sucking at the dry breast. That means that mom needs to pump immediately before the feed. We don't want baby to actually get any milk during this. It's just a practice of sucking. So if mom says, well, I pumped an hour ago, that doesn't count. She needs to pump immediately before the feed. And that's 30, we can start that at 30 weeks. At 32 weeks, if the infant is tolerating bolus feeds, not continuous, that's important, it should be bolus feeds, and they have no signs of respiratory distress, and they're on less than 2 liters of nasal cannula, we will continue with their bolus feeds and start discussing with the medical team the initiation of the feeding pathway, and this is what we consider the feeding pathway. The very first step in the feeding pathway is to discuss with the mother what her preferred method of feeding is. So we need to know if she plans to breastfeed or bottle feed. At that point, once we have decided what mom's going to do, we'll perform an infant readiness assessment before each feeding. So we need 4 documented scores of greater than 5 in a 24-hour period to begin safe feedings. So that means if we decide today that baby is ready to start feeding, we still need to do the readiness score for 24 hours, and 4 of those need to be greater than 5. If they are, tomorrow, then we could start the readiness scoring and the quality scoring. If the baby happens to have an OG tube, we would need to change that to NG unless there's a medical reason not to before we start PO feeding. So readiness score is greater than 5. If the mother is breastfeeding, you move on to the breastfeeding algorithm. If the infant is bottle feeding, you're going to complete the quality assessment after each feeding. If they have a quality score of greater than 5, but they're less than 2 kilos, You'll gavage the remainder if the infant doesn't complete the volume in their 30 minutes or if they show any signs of disengagement or distress. Then you would continue with the readiness scoring for the next feeding and keep going. If the infant is greater than 2 kilos and they take 85% or more of their feeding, you do not gavage the remainder. You only gavage if they take less than 85% and are less than 2 kilos. Again, you'll reassess their readiness at the next feeding. If their quality score is less than 5, you'll stop the feeding and gavage the remainder. Do continue to do readiness scorings before each of the next hands-on. Nursing should contact speech for an evaluation if we have 3 or more quality scores of less than 5 in 24 hours. Those do not have to be consecutive. If 3 times in 24 hours you get a quality score of less than 5, please get with speech. If you work night shift and you don't see speech, make sure you let the day shift nurse know the next morning so that the day shift nurse can get in contact with speech for an assessment. Also, if you have an acute onset of quality scores less than 5, so your baby has been eating for several days and their quality scores have been between 5 and 10, and now suddenly you're getting quality scores of less than 5, that needs to be brought up to the medical team for them to do an evaluation. That leads to concerns for sepsis or aspiration or some other type of medical decompensation. But I think it's pretty clear that if your baby's quality scores are going down, it's likely that something else you've already noticed. They're either having spells or some other change in their status. If they have a readiness score of less than 5, you're not going to bottle feed for a readiness score of less than 5. You're going to offer the pacifier and gavage feed. You can begin bottle feedings once the readiness score allows. So once you have readiness scores of greater than 5, you can start that bottle feeding. It's also important to note that if your baby is greater than 35 weeks and continues to have readiness scores of less than 5, you need to talk to the medical team so that they can make a plan for that baby's care. If the baby is completing 6 or more feedings in 24 hours, you can discuss with the medical team taking out the NG tube and offering a volume range for ad lib. The medical team should be notified if they are unable to consistently meet that ad lib volume. We'll move on to the breastfeeding algorithm. So the decision has been made by mom to breastfeed, and that would be validated if the infant is receiving bolus feeds with a minimum daily volume of 120 mLs per kg per day. You will perform the readiness assessment prior to each feed, just like you would if you were going to bottle feed. If the score is greater than 5, you'll allow that infant to breastfeed and complete a quality assessment during each feed. So for breastfeeding, a quality score of greater than 5 is if you fed less than 5 minutes, you'll gavage the entire feed. If the infant fed 5 to 10 minutes at the breast, you'll gavage half the feed. If the infant fed for 10 minutes or more, you'll do not gavage any. Now again, that's all for quality scores at the breast of greater than 5. You'll continue with the breastfeeding attempts as the mom is available. One thing I would like to point out that is a little bit different is you'll notice I said gavage. So currently we frequently let the baby go to breast and then offer a bottle if they do not do as well at the breast. But the goal is to get these mamas breastfeeding. So we'll gavage the difference if they don't feed well at the breast. If they have a quality score of less than 5, you're going to gavage the whole feeding. You will continue the breastfeeding algorithm. If you have more than 3 quality scores, less than 5 in 24 hours, it's going to be a little bit more. You're going to consult speech. You'll also consult lactation. You'll have the mother and the RN at the bedside. And we want all those people to meet together at the same time. So we don't just have speech consult and lactation consult. We want speech, lactation, and the nurse with the mom at the bedside all at one time to assess for any further special breastfeeding needs or discuss what the future plan for feeding will be. I realize that that might be difficult on night shift, but please let your day shift nurse know so that we can coordinate that with the mother and the appropriate members of the team. Daily weights will be carefully monitored during the transition from gavage feeding to breastfeeding to ensure that the infant has proper growth and is getting enough. Also, there will be a daily assessment, ideally by the lactation nurse, to determine if the mother's breast milk volume per pump is at least equal to 1 feeding volume. So if your baby is receiving 55 mLs and the mom only pumps 30 mLs, it's unlikely that the baby will be able to get enough at the breast. So we need to know how much the mother is able to pump. Compensatory techniques will be talked about by Mary Jane.
Before we go to compensatory techniques, I just want to emphasize the breastfeeding part of this is that we really want to encourage and support our moms who want to breastfeed to be able to do this successfully. Oftentimes I hear in the unit from parents that, oh, I want to breastfeed, but I'll do that at home because the bottle is the quicker way for me to get out of here. All of us are here, lactation's here, speech is here, you all are here. We are the support system for this mom and this family to be able to successfully breastfeed. So we need to utilize all those resources in-house so that this baby and this mom can learn to successfully feed at the breast if that's their desire. I can't tell you how many families I see in the developmental NICU clinic after discharge follow-up where this baby's 4, 6, 8 months old and mom's still pumping 8 times a day because they weren't able to transition to the breast. That's a lot of work for that mom and that family. Kudos to her for keeping that up. But if we can do anything on our end here in the unit to help her transition to breastfeeding and minimize that work of pumping, that's what we want to do and support this developmentally appropriate process. Some of the ways that we can help facilitate safe oral feeding, either the breast or the bottle, are by the use of compensatory techniques. One of which is through positioning, and I am encouraging everyone to feed their babies in a sideline position. So that's a little bit of a transition from a cradle-held upright position, but more of a sideline, which is a developmentally appropriate position. Also elevated with your sideline, not just flat on the lap. The use of pacing, which helps teach the baby to self-regulate themselves when sucking. Some babies will just suck and suck and suck on the bottle until they wear themselves out or until they choke or Brady. But we have to be the careful observers to say, you haven't taken a breath yet, you're having a hard time integrating breathing with your sucking, so I'm going to teach you how and when you need to pause to help with coordination as well as energy conservation. Swaddling. Swaddling is a big developmentally appropriate technique that we can give our babies. Swaddling helps with organization, and if we have motor organization and motor coordination of our limbs, that's going to transfer up to the mouth and help the baby be much more successful with oral feeding. There's a little bit of debate on, well, if I swaddle, they're going to get sleepy and not want to feed. I'm not saying you have to swaddle like a burrito, but a gentle swaddle that provides developmentally appropriate boundaries and helps with organization is going to help with feeding. Oral stimulation. So some of our babies are cueing. They're awake, they're alert, they're kind of fussy, but going to the bottle first is a little tricky transition. They may push it away, they may gag, they might choke initially. So sometimes they need a little bit slower introduction to the bottle, and we can help with this. So you're holding in that nice sideline position. Offer the passy first. They're swaddled, they're organized motorically. The pacifier is going to help their oral motor organization. Once they've established a coordinated suck pattern on the pacifier, then you can take the pacifier and dip it in milk. If it's breast milk, if it's formula, just offer a passy dip to the lips. See if they'll pull that passy in and start sucking. Once they've established a coordinated non-nutritive suck on the pacifier with a passy dip, then you can transition to the bottle. And when I mention transition to the bottle, I'm not talking about like forcing it in the mouth initially. Take it to the lips, let them smell, let them taste, rub it around their lips. Give them the opportunity to open their mouth and pull it in and start sucking. We're just giving them the support they need to be able to take the bottle in and start sucking in a coordinated, organized fashion. We have chin and cheek support on our list of compensatory techniques, just to bring up the point of please do not use these compensatory techniques. Chin support increases the flow from the bottle. So with chin support and a good latch, you're increasing the amount of milk the baby is getting at a time and forcing them to swallow more than they can handle. So please do not use chin support. Cheek support does the same thing. Ashley's going to talk about daily rounds.
So daily rounds. The medical team during rounds wants to know how your baby is doing. So they come up, they say, how's your baby feeding? If you just say, good, that doesn't really tell them what they need to know. Or, not so well. Again, they don't know what's really happening with your baby. Those one-word answers are usually not appropriate. So we really need to do a good job as nurses in keeping the medical team involved and informed about what's happening with the baby. So, good items to address during rounds with the medical team are, if your baby is, say you're the 30 or 31 weeker who's doing the non-nutritive sucking, let them know, hey, mom was here, we did some skin to skin. We offered the passy during the gavage feeds and they're doing really well. Or they're not doing so well, they are not handling that well. Just let them know that it's happening or not happening and why. Scores, now that we're going to have these scores, of course, the medical team will be able to see those, but it's very helpful in rounds to let them know, is your baby's readiness scores good? Are you getting readiness scores of 5 or greater almost every time, or are you rarely getting readiness scores of 5 or greater? How many times did you get that 5 or greater in the last 24 hours? Same with quality scores. Hey, my baby is ready to eat every time. We have these really good readiness scores, but my quality scores are poor. Let them know what your scores are and how often you're getting them. If your baby is breastfeeding, it's important to let the medical team know how many times the mom is here at the bedside available to feed. There will come a point, likely with every baby, that we will transition from the breastfeeding algorithm back to the bottle feeding algorithm and sort of use them both. And the reason for that is, obviously, the moms can't be here for all 8 feeds throughout the day. That would be very difficult. So at some point, to get the baby transitioned to home, we're going to have to offer some bottle feeds. So that will be determined how soon we offer bottle feeds and how often we offer bottle feeds based on the mom's availability. And those physicians need to know, hey, I haven't seen this mom in 3 days, but she let me know that her plan is to breastfeed. That may not be the best scenario for the baby, so they need to know when moms are here. If you're bottle feeding your baby, the number of times the baby took a bottle in the last 24 hours, and if they are or are not completing those bottles. Yes, we are moving away from volume-driven feeds, but at the end of the day, to grow, they're going to need a certain amount. So we're not pushing the babies to take it, but we need to know if they are or are not taking the full volume. Also, let the physicians know if the parents are participating in feeds. At the end of the day, it doesn't matter if I can feed their baby. If they can't feed their baby safely and read those cues, then they're not ready to take that baby home. So it's important to know if the parents are here at the bedside, if they're engaged, and they're making attempts to feed their baby, and how well they're doing. PO ad lib. So we talked about this when we talked about the algorithm, but we'll talk about it again. If the baby has completed 6 of the bottles in the last 24 hours, is it time to make that baby's volume ad lib, or do we need to stick with a very specific amount? Problems. Discuss with the medical team. Are you having any problems? Are you having any concerns? And most of those things are going to be things that we've already talked about, but there might be something else that you need to address, or you have concerns with making sure everybody's on the same page. So please talk to the medical team. For those of you who are on night shift and day shift, but especially night shift, it's really important that in the morning handoff, we have an idea of what happened in the last 24 hours. Whether we were back from the day before with the same baby, or maybe it was a different nurse yesterday and you were there overnight and we're here today. Those are things we have to report in rounds. And the medical team does not have time, nor do they want to stand there while you scroll back through the flow sheets to see what your scores were or how often a mom was here. So it's going to be important and helpful to add that to the handoff. If you could please just go ahead and type it into the handoff, that would be great. But at the very, very least, please pass that information along, because it's going to be vital in making sure these babies are progressing as we expect them to. As far as changes in our EPIC charting, so the hope is to have this available on the EPIC playground for us to play with sometime in December. The go live for the new Q-based feeding program is January 6th. So we hope that some of you are able to start practicing this and playing with it before go live. I don't know exactly when it's going to be available on the playground, but we will let everybody know when it's available. Okay, some changes that are taking place for intake. So PO medication delivery. Any PO medication should be given at the end of the feed. It should either be mixed in the syringe if you're feeding your baby over a long time or continuous, or it should be mixed into the bottle. You don't want to offer the baby a bottle but yet just push their medicine through their NG tube if they have it. Because of osmolality, that increases their risk of neck or perforation. So we want to make sure that they're getting their medications on a full tummy. For scanning breast milk, no change. It will stay the same. For the oral care or the milk drops that we're going to do with whatever kind of milk the baby's receiving, in the first 5 days, it's going to be important to note whether or not the baby got colostrum from the mom. So you'll be charting, yes, they got colostrum, or there was none available, each hands-on time for those first 5 days. That's going to be important. Once you move on to the milk drops portion, it's no longer colostrum, but just express breast milk, donor milk, or formula, you'll need to notate exactly what you used, not just for the feed, but for the oral care. And the reason that's important is, many of you know, sometimes mom has milk, but yet we're supplementing with donor milk or formula. If we're using mom's milk for the oral care, but maybe donor milk for the biggest part of the feed, we need to be differentiating, you know, what is being used as the oral care and what's part of the feed. As far as the feeding orders, there's no change in EPIC. However, there will be a place in EPIC now for us to just enter in the donor milk serial number and lot number, as well as the HMF serial number and lot number, so that you won't have to go in and make a comment each time. There'll be an actual line to document that, just like there is for formula now. Formula is not going to change in EPIC. The type of PO feed. So we're going to be saying, is this a non-nutritive feed? So the pacifier, the pumped breast, you'll be marking which one you're doing. If it's a bottle feed or a breast feed, you'll chart the nipple type, duration, the technique, who it was fed by, and you'll have all those choices just like we do now. So that's not going to change too much. What is going to change is the breastfeed. So as you know now in Epic, it just tells you like, it has the weight before and after, and left breast and right breast. No more of that. It'll just be duration, less than 5 minutes, duration 5 to 10 minutes, or duration greater than 10 minutes, because as the algorithm progresses, that tells you how to proceed with gavage or no gavage. And also with breastfeeding, what type of assistance was used? Did they have to use a nipple shield? Was a lactation nurse at the bedside? Was the RN present at the bedside providing assistance? Or was the mom independent in breastfeeding her baby? There'll be a place to chart whether or not mom's milk supply is adequate for each feed. So again, if she's not making enough to provide at least one feed, we need to be documenting that, and that will help document why we're using donor milk or formula. The LDA section. So currently there is some confusion about the OG-NG is a Repogal, but it says OG-NG, and the feeding tube, which we call an OG tube or an NG tube, can sometimes be mixed up. So it's going to populate the appropriate lines just like we have now. Just when you search it to enter it, if it's a Repogal, it's going to be called a Repogal. If it's a feeding tube, it's going to be called a feeding tube. If you're using your feeding tube to vent, it's still a feeding tube. So an OG-NG will be used just for Repogals. Also, this is a big change. The IV fluid section will be found at the bottom of your intake and output section. So it's just going to change the order of that flow sheet, but not necessarily what's on it. Changes that are being made to the output. Again, it's just the order. It's not what it says, but the order in which they're listed. So you'll have your urine output and its description, your stool output and description, emesis description, or I'm sorry, not stool output. You'll just have urine output, urine description, stool description, emesis description, and then drains. So no more of that like mixed stool, not mixed stool, all that. It'll just be urine output and the descriptions of each.
So based on those videos, to start off, I think there's some developmental supports that we can put in place. Both of these babies are a little disorganized. You see their arms kind of out and about, so we could offer some more swaddling with some containment to help with organization, hands at midline to begin with. But then if I scored their readiness score on state of consciousness, the baby was awake and alert, so I would give him a 2. On feeding readiness cues, it was opening his mouth with the nipple presented. I would again give a 2. Tone looked decent. Again, with a little bit of swaddling, developmental support, I think we could get him in a flexed position. Vitals appeared stable, so again a 2. And there were no signs of stress noted, so a 2. So this baby would get a readiness score of 10. And based on that score, we would proceed with oral feeding. We'll look at another video now and score quality on this baby. So if you'll look at your quality scoring tool, she she's in a very nice sideline position, hands at midline. Seems pretty organized in the beginning. So if we start with the quality tool and we start with the suck, she appears to have a strong coordinated suck. So that would be a score of 2. Her coordination, I would score her a 1. She's having a little bit of difficulty integrating breathing with her sucking pattern here, and you can hear a little bit of that if you listen really closely. She's not sure when she should pause and take a breath, so I would give her a 1. Her state of consciousness score, she is awake and alert, as we're observing in this little clip of feeding, and she's able to maintain a good flexed position. So a score of 2 with state of consciousness. Physiologic stability, we don't hear any alarms going off, so we're going to assume that her vitals are good with a 2. And stress. I see some subtle signs of stress in this video clip. And if you watch her face very closely and listen, she's got some eye blinks, a little bit of grimacing through her forehead, and you can hear her struggle to try and integrate breathing and swallowing. So I would score her a 1. And that would give her a total quality score of 7. Based on that score, we could continue with oral feedings.